this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
So my name is Mary. I'm currently a PGY2 at CHRISTUS, and today we're going to be talking about INTERACT3. So key objectives for today are to review the acute management of spontaneous intracerebral hemorrhage, or ICH, discuss previous literature that evaluated bundled care in ICH, and of course evaluate the INTERACT3 trial. So for a little bit of background on spontaneous ICH, this is caused by a cerebral blood vessel rupture that leads to blood extravasation into the brain parenchyma and, of course, brain injury through a wide variety of mechanisms such as local tissue compressions, as well as elevations in intracranial pressure, ICP. It accounts for about 10 to 20% of all strokes. The incidence is closer to 10% in the United States, but it's closer to 20% on a more global level. And we do see a higher burden of ICH in those low to middle income countries, particularly due to suboptimal management of chronic hypertension. It also has a very, very high early mortality rate of up to 40%. And there are many predictors of worse outcomes, such as hematoma expansion, which is really our most feared complication. And a lot of our early interventions are targeted at minimizing hematoma expansion. Elevated blood pressure and use of anticoagulants can also worsen hematoma expansion as well as increase mortality. Hyperglycemia and fever are also associated with worse outcomes. And of note, temperature abnormalities can actually occur in up to 30% of patients. So this can be really common. For acute management, we first want to start with airway protection through intubation if needed. Many of these patients will present with depressed consciousness, followed by a head CT to confirm the diagnosis of ICH. And then we have many initial management strategies, such as blood pressure lowering, anticoagulation reversal, ICP management, and surgical intervention, such as a hematoma evacuation. And then have more generalized ICU recommendations, such as blood glucose and temperature management, so more supportive care. In terms of what the guidelines say, so in terms of blood pressure lowering, we only have lower level class 2 recommendations in this area, but it's recommended to initiate treatment within 2 hours and reach a target within 1 hour. And this is to reduce the risk of hematoma expansion and improve functional outcomes. The target blood pressure goal is less than 140 with a range of 130 to 150. And this is to improve functional outcomes. In terms of anticoagulation reversal, we do have a very strong class 1 recommendation in this area that this should be performed as soon as possible to improve survival. Moving on to blood glucose management and temperature management, we don't really have as much evidence that is specific to our ICH patients in these areas. And as a result, the guideline recommendations are a little bit less clear. So this is definitely an area where more research is needed. But it's recommended to treat hypoglycemia to reduce mortality. And this really comes from more generalized ICU trials, such as the NICE sugar trial. And it's also recommended to treat moderate to severe hyperglycemia to improve outcomes. So overall, we don't really have prospective RCTs looking at our ICH patients for blood glucose management. We really just have some observational data to suggest that hypo or hyperglycemia can worsen outcomes. For temperature management, fever can worsen outcomes. However, actually treating a fever hasn't really been shown to improve outcomes. So we again only have a lower level recommendation that treating a fever may be reasonable. So overall, blood glucose and temperature management are really areas where we need a little bit more research. And there isn't a specific blood glucose target or a specific temperature target or really any specific medications that are actually recommended. I did want to highlight some key randomized controlled trials that were landmark studies and did inform the guideline recommendations for blood pressure lowering. The first was ICH ADAPT in 2013 that compared a systolic pressure less than 150 to less than 180, and they found that there was no difference in relative cerebral blood flow. So this trial really just dispelled that myth that rapidly dropping blood pressure could potentially precipitate cerebral ischemia. So the whole point of ICH ADAPT was to support the safety of blood pressure lowering that was being studied in INTERACT2 and ATTACH2, which were ongoing at the time. INTERACT2 looked at patients who had a systolic blood pressure of 150 to 220, and they compared a systolic pressure of less than 140 to less than 180. And they found no difference in death or disability at 90 days, but they did find lower MRS scores for the intensive blood pressure group in an ordinal analysis. ATTACH-2 looked at higher blood pressures than INTERACT-2, so they looked at patients with pressures of 180 to 240, and they compared a much lower systolic blood pressure of 110 to 139 versus 140 to 179. And they again found no difference in death or severe disability, but what they did find is that there were more renal adverse events in that intensive blood pressure group. So overall, I think it's really interesting to note with these two studies that these are really our most two important landmark studies that inform those guideline recommendations, but didn't really see much of a positive outcome. And I think this just really goes to show how high the morbidity and mortality rate is for this disease state. Where we did see a benefit, though, for blood pressure lowering was in later meta-analyses that did find a reduction in hematoma expansion. And there was actually an analysis conducted of INTERACT2 and ATTACH-2 that did show an improvement in functional outcomes for reaching those blood pressure goals. But overall, it's important to note that those benefits were not seen in those original two randomized controlled trials. Looking at bundled care in ICH, we have two studies to date. The first one was a 2011 study. This was a cluster randomized controlled trial, but a limitation here is that it only looked at ischemic stroke and acute ICH. And they studied the FEST protocol, which stands for fever, sugar, and swallowing. So they treated elevated temperatures with acetaminophen. They used insulin to treat sugar elevations, and the exact threshold depended on if patients had diabetes or not. And they conducted swallow evals within 24 hours. The ABC ICH project in 2019 was just an observational before and after study, so this wasn't an actual randomized controlled trial, but a strength was that they did only look at the spontaneous ICH patients. They applied the ABC care bundle, so it looked at rapid anticoagulation reversal with PCC for warfarin or DOACs within 90 minutes, as well as intensive blood pressure lowering. And again, we see that target of 130 to 140 within 1 hour, so kind of similar to what the guidelines recommend. And of note, these were two key interventions that were studied in INTERACT3, as well as immediate neurosurgical referral. Overall, the 2011 study found that the post-intervention group showed decreased suffer dependency at 90 days, and the ABC ICH project found that there was decreased 30-day mortality during and after implementation of the bundle. So overall, it's really interesting to note that these two studies actually did find a positive outcome for ICH, which is something that we didn't see in those two previous landmark trials for blood pressure lowering. And overall, this is some pretty good preliminary evidence that care bundles could improve outcomes in ICH. I also wanted to point out that there was actually a post hoc analysis conducted of INTERACT2 in 2021. And this was actually performed by investigators of INTERACT3, which was ongoing at the time of this analysis. And they basically assigned baseline scores to abnormal physiologic parameters, such as systolic blood pressure elevations, blood glucose and temperature elevations, as well as warfarin use. And they found that higher scores were associated with major death or disability at 90 days. So overall, this provided some pretty compelling rationale for the INTERACT3 study. So we do have some pretty interesting data that care bundles improve outcomes, and not treating those abnormal physiologic parameters can worsen outcomes. The guidelines don't actually have a specific recommendation for bundled care at this time, but they do mention that the potential benefits of a bundle of care should be studied. So we are trying to see an interesting shift in our ICH management from isolated intervention to actual care bundles and protocol implementation. And this is something that already exists pretty commonly with our acute ischemic stroke patients, where we often will have protocols and code stroke activations, and those patients tend to be treated with it very aggressively with a lot of urgency. So we have very, very strict door to needle times and door to imaging times. Whereas that doesn't really exist for our ICH patients. A lot of times these patients are managed much more conservatively in a much more palliative manner, just because we accept that the morbidity and mortality rate is unfortunately so high, regardless of what we do. So it is really interesting to see the shift in management for ICH. But we do need more randomized controlled trials to really see if these protocols actually impact patient outcomes. So in comes the INTERACT3 trial. So this is the first randomized controlled trial that has evaluated care bundle that included blood pressure lowering in acute ICH. Their bundle included management of blood pressure, blood glucose, treatment of pyrexia, followed by anticoagulation reversal. In terms of its design, this was a pragmatic, international, and multi-center study. So they looked at 10 countries at 120 hospitals. Of note, most of the countries were in low to middle income countries, and those are the countries where we really see the highest burden of ICH. And of note, none of the countries were in the United States. They used a blinded endpoint, as well as a stepped wedge and cluster randomized design. So it's cluster randomized, meaning that every hospital was a cluster, and the randomization was on the hospital level as opposed to the patient level. And that's really because many of these interventions are very time sensitive, so enrolling individual patients can cause a lot of delays. In terms of this stepped wedge design, the randomization was to sequence 1, sequence 2, or sequence 3, and not usual care versus care bundle. So the sequence basically determined at what time point the hospital would transition from the usual care group into the care bundle. So there were 4 different time periods. During period 1, every hospital was in the usual care group. And then sometime during period 3, or period 4, the hospital would transition from usual care to care bundle. And then during period 4, every hospital was in the care bundle group. So during period 4, of note, there was no control group because everyone was in the care bundle. And overall, this was a discovery implementation type design. So investigators were trying to mimic what the process of rolling out a quality improvement project would look like. In terms of inclusion criteria, they looked at adult patients with spontaneous ICH who presented within 6 hours of stroke onset, and they excluded patients who had a secondary ICH that was due to a structural abnormality such as a traumatic injury or an aneurysm, or even an ICH due to reperfusion therapy such as thrombolysis, as well as patients who had a low likelihood of adherence to the study treatment. Their intervention was a protocol maintained for 7 days versus usual care, and there were 4 components of the care bundle. So early intensive blood pressure management with a goal of less than 140 within 1 hour, and their lower threshold was 130. They also looked at intensive control of elevated blood glucose, and their blood glucose range depended on if patients were diabetic versus non-diabetic. And that was to be implemented as soon as possible after treatment initiation. For treatment of pyrexia, their goal was less than 37.5 within 1 hour. And then for anticoagulation reversal, this was only in patients taking warfarin. So they actually didn't mention patients who were on direct oral anticoagulants because, again, the study wasn't conducted in the United States. And that was to be conducted using fresh frozen plasma or FFP or PCC. And their goal INR was less than 1.5 within 1 hour. So as you can see, these interventions are mostly within 1 hour. So these are very, very early interventions, pretty much in the emergency department. In terms of the outcomes, the primary outcome was functional recovery at 6 months, and that was defined as a shift in the modified Rankin Scale score across all categories. And so this is going to be an ordinal endpoint. And for secondary outcomes, there are way too many to mention for the sake of time, but I did want to point out some key ones, which were a dichotomous analysis of the MRS scores at 6 months. So that's looking at the MRS score, the more nominal endpoint, as opposed to an ordinal endpoint, which is what the primary outcome was looking at, as well as death at 6 months. And investigators chose 6 months as opposed to 3 months, which is what most studies typically look at, because they noted that ICH patients do tend to have a much longer recovery time. They also looked at death or neurologic deterioration at 7 days, as well as quality of life, place of residence, and hospital discharge. For stats, they used a 90% power to detect an odds ratio of 0.8. They targeted a sample size of about 8,000, used an alpha of 0.05, as well as an interclass correlation coefficient of 0.04. And their primary analysis was an ordinal logistic regression using a modified intention to treat principle. So they included patients who consented and had primary outcome data available. Moving on to results. So starting at the top, I wanted to point out that the study included about 7,000 patients. So it's very, very large, but they actually still didn't meet power, which would be about 8,000 patients. Most patients were males who were about 60 years old, and almost all patients were of Han Chinese ethnicity. And that's because China was really the main country that patients were enrolled from. About 70% had a hypertension history, and 10% had a diabetes history. And before the stroke occurred, most patients had an MRS score of 0, which is no symptoms. So these patients were very, very healthy and high-functioning patients. On presentation, the median NIHSS score was 13, so that indicates a moderate stroke severity. And the median systolic blood pressure was about 174 in both groups. And they also denoted that hypertension was really the predominant cause of ICH in well over 90% of patients. In terms of abnormal physiologic variables, about 90% had an elevated blood pressure over 140. About a third of patients had hyperglycemia, and only about 1% of patients had temperature and INR elevations. So this is really important to note is that when we think of our care bundle, the blood pressure lowering component represents almost everyone in the trial. But looking at the other key components, especially for anticoagulation reversal and temperature management, we're unfortunately looking at a very, very small percentage of patients in this study. Looking at the actual implementation of the care bundle, so for blood pressure management, more patients in the care bundle group received an IV blood pressure lowering treatment during the first 24 hours. More patients reached the target, and they reached that target faster. So the median time to target was 2.3 hours for the care bundle versus about 4 hours for usual care. So they still didn't reach, though, that 1 hour goal target. As you can see in the image below, this depicts the control group in red and the intervention group in blue. And you can definitely see that the blood pressures in the intervention group are much lower. So it was lower by about 7.3 hours at 1 hour and by 3.6 at 24 hours. So overall, the care bundle group did have lower blood pressures, especially during that initial time period. Looking at other components of the bundle, so it's important to remember that we are talking about a much, much lower percentage of patients in this study. But in terms of blood glucose management, more patients received treatment and reached the target. And however, they reached the target at about the same time. So it was about 1 hour for both groups. In terms of treatment of pyrexia, again, more patients in the care bundle group received treatment and reached the target. And they reached the target faster. So it's 3 hours for the care bundle group versus 4 hours. So again, did not reach that within 1 hour target. However, for both the blood glucose bundle and the temperature management portion of the bundle, the actual blood glucose values and temperature values during the first 24 hours didn't really differ that much between the care bundle and usual care group. So overall, not really seeing as much of a difference as we did for the blood pressure lowering. In terms of anticoagulation reversal, so huge limitation here is that this is a very, very small number of patients. It was only about 11 patients in the care bundle group versus 15 patients in the usual care group. And this was mostly warfarin. There were actually only 2 patients in the entire trial who were on rivaroxaban. And the investigators really concluded that there were no clear differences noted for anticoagulation reversal. And I did want to point out how long the time to target was. So it was 27 hours in the care bundle group versus about 25.5 hours in the usual care group. So this is much longer than their goal, which was within 1 hour. In terms of what medications were used for blood pressure management, their most common agent was urapidol, which, as we can tell, is not available in the United States, followed by sodium nitroprusside, labetalol, and nicardipine, which is about 8% of patients, and nitroglycerin. For blood glucose control, oral agents were used in about 80% of patients, and insulin was only about 22 to 27% of patients. And then for treatment of pyrexia, hypothermia cooling with cap packing was most common. Acetaminophen was used in 12 patients versus 15 patients. We also had IV cooled saline infusions and metamizole, which is another drug that we do not have in the United States. Looking at the outcomes, so their primary outcome was a shift in modified Rankin scale scores. So that was an ordinal endpoint. And they actually did note a shift for the care bundle versus the usual care group. And this held for both the unadjusted and adjusted odds ratio. So the adjusted odds ratio was for things like country or other patient variables. And you can also see in the figure below is that we do have more patients in the intervention group who had an MRS score of 1, which is maybe mild symptoms, but no actual disability. We also have less patients in the intervention group who have those higher MRS scores of 4, 5, and 6, which is death or major disability. Some key secondary outcomes is that the care bundle did reduce mortality at 6 months. However, this was only for the unadjusted odds ratio, not the adjusted odds ratio. They also found no difference in major disability, which was an MRS score of 3 to 5 at 6 months. So it's interesting to note that when we look at the MRS score as an ordinal endpoint, we find a difference, but not when we look at it as a nominal endpoint. They also found no difference in death or neurologic deterioration at 7 days, but they did find that there were fewer serious adverse events for the care bundle group versus the usual care group. Authors ultimately concluded that findings do support the adoption of an active protocol for intensive blood pressure lowering and the management of other abnormal physiologic variables to improve recovery. And investigators also noted that blood pressure lowering was really the key component of the care bundle that was driving the benefit. It's also interesting to note that this is really the first 3 multi-center RCT that actually showed a positive outcome for an acute treatment of ICH. So as we think back to those landmark INTERACT2 and ATTACH2 trials, even though those trials are very large and very important, they didn't really show any benefit in terms of death or functional outcomes. So it's really significant that this trial actually did show a benefit. Moving on to critique, so the main strength of the study is that had a very, very large sample size and a very, very diverse patient population, and they really focused on the part of the world that does see the highest burden of ICH. So it was a huge strength of this trial, and it was much larger than even those landmark trials like INTERACT2 and ATTACH2. However, there are some important limitations to note. So first off, the usual care group was not clearly defined. So even though this was a randomized controlled trial, it didn't really have a clear control group. And it's also interesting to think about that this trial was a stepped wedge design. So every hospital started out in the usual care group and then was transitioned over into the bundle group. And during that time period, hospitals knew that they were being evaluated in an ICH study because it wasn't entirely blinded. And that can introduce a lot of bias, and we could potentially see a benefit that's just because hospitals knew they were being evaluated and that could improve care. That's not necessarily due to the actual components of the bundle. So overall, as well, that the randomization, it wasn't to control versus intervention, it was to different sequences. So overall, even though this is an RCT, we do kind of have to interpret this study more so as like an observational before and after type study. The stepped wedge design can also introduce a lot of confounding bias, particularly due to time and the COVID-19 pandemic, which unfortunately happened right in the middle of this trial. So in trials that use the stepped wedge design, one of the ways that investigators account for confounding by time is by having a lot of overlap between the control and intervention groups. So we want control patients and intervention patients to be evaluated at the exact same time. And that happened during periods 2 and periods 3 in this trial. However, once we got to period 4, which is at the very end of the trial, there was only a care bundle. So that there was actually no control group at that time. And in some of the supplementary data, that actually did prove to be significant. So they did a subgroup analysis where they looked at the modified Rankin Scale scores, so the primary outcome, and they compared before and after the COVID-19 pandemic, as well as looking at China, which was entirely enrolled before the COVID-19 pandemic, versus other countries that were entirely enrolled after the COVID-19 pandemic, and where they saw the benefit in modified Rankin Scale scores was in those later time points. We definitely know that that could introduce a lot of bias, especially toward that primary outcome. Because this trial was not conducted in the United States, it also could have some limited external validity. As we saw in this study, there was very, very limited use of DOACs and very few patients required anticoagulation reversal. Here in the United States, we would expect that way more patients would be on DOACs and way more patients would get anticoagulation reversal. And really your 2 most important interventions in our practice is blood pressure lowering and anticoagulation reversal, but it just wasn't as well represented in this trial. The specific medications that were used were also a little bit different. If this was conducted in the US, we would really expect that most patients would get cardine or labetalol or clofidipine. So overall, the study builds upon prior evidence to support intensive blood pressure lowering to a goal of less than 140. And it really spotlights the need for actual protocol development in acute ICH, like we kind of already see with our acute ischemic stroke patients. And it also provides some very much needed additional data for glucose and temperature management that is specific to the ICH. And overall, it really is a good reminder that maybe we should be a little bit more focused on glucose and temperature management earlier on, because our time goals for these were as soon as possible and within the hour. So that could very much be within the emergency department. But we oftentimes are only really focused on blood pressure control and bleeding reversal. So thank you for listening, and I can take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.